Yeah, I'm driving. I'm just listening to you.
Okay.
Yeah, I just out of work. I was like, no, I will not miss this study group. And I don't want you actually. I don't know who like commented that, but it's like I don't want you actually after your class to do another lecture for us. That's just a headache. So you need to relax a little bit, or like your heart will explode.
Thank you. I don't want to die, but I want us all to pass.
Yeah, that's why we don't want you to die too. You know, this is safety issue here.
Safety. There. Thank you. But I want us all to do well. We're running out of time, so the time is very precious right now.
Yes, yeah, that's why. That's why. Like whenever that we get and you're fully conscious, we will take that.
Okay. Are you locked, cocked, and ready to
Mm,
rock? Here we go. Damn it. Hold on.
I'm fully listening to you.
Hello, Paula. What's up? No, Zakia's on. Zakia's on. Zakia's on.
I'm here, Hala.
Paula.
Congratulations, Hala. Good
Zakia's
job.
on. Okay. And there we are. Okay. So let's go through this very quickly. Have you been on the study group for 13 yet with me?
Are you talking to me, Chris?
Yes.
Yeah, just like for 10 minutes or 15 minutes last night. That's it.
Okay. So let's get into this thing hardcore. Okay. So let's get into the risk factors. And today I haven't been digging down as deep, but now we're going to dig down into these risk factors and we're going to go through them until we learn them. Are you ready? So get your
Yep.
notes out if you need to. Let's get into these and let's learn these risk factors. Okay. So some of these are intuitive, right? Some of these risk
And
factors are the same for everything else we've done.
yeah, yep.
Okay, so let's go through the ones that we kind of can guess. If we don't know, what can we guess?
Okay. So that's the question, right? Tell me the title again because I missed it.
So we're on Unit 13. We're on integumentary, right? We're doing skin. So what are
Uh
the
huh.
risk factors for skin problems?
Okay. Risk factor like the thing that came with malnutrition, sun, burn. Um, let's see. I don't know. So I don't like what would cause our skin to be like dysfunction, right? Is that the
Yeah,
correct
what
way to
what
ask?
what what makes our skin be at risk for problems, for skin injuries?
Okay. Family history of cancer, skin
Yep.
cancer.
So skin so family history so pigment trauma so skin pigment. So are people with darker skin or people with lighter skin more at risk for skin problems?
I think it's that no, the Caucasian or like lighter skin is more in danger
Yes.
for some of yes,
Yep. So lighter skin is traditionally a little bit more of an issue for skin problems.
yeah.
So that's traditionally what's going on with that. So yes, you're absolutely right on that one, Kay. So lighter skin people are traditionally a little bit more at risk than those who are of darker skin, right? So that's just that piece. So
Uh huh.
everything's good. So we're there. Okay. The next one is ethnicity. So which ethnicities have the highest risk for skin problems?
Fair skin, like fair.
Yeah, fair skinned people, right?
Yeah.
So those of us who are Caucasian in nationality,
Caucasian. Yeah.
we're a little bit more at risk than those who are not.
Okay.
Okay. Round two, here we go. Okay. Exposure to chemicals, radiations, and excessive sun. That's pretty straightforward. Though if we expose somebody to radiation or
Uh-huh.
sunburns, they're more at risk to have skin problems.
Okay. Radiation and chemotherapy. You said chemotherapy.
Not just chemotherapy. Chemotherapy, yes, but for example, say you're a worker who works out at the Thiokol Corporation out here in Magna. They make rocket fuel there. Can those kinds of chemicals burn your skin?
Uh huh.
So yeah,
I
so
see.
chemical burns is one of the things they were talking about.
Okay. How about allergy reaction? Is that there?
No, allergic reactions is not, but pathogens is. So exposure to bacterial, fungal, viral, or parasites can predispose people for skin injuries.
Okay.
So
Pathogen.
yes,
Okay.
that's not there directly as like pathological. I mean, like, but they're just saying that pathogens can predispose people to potential skin problems. And that makes
Okay.
sense, right? Like cellulitis and dermatitis, by definition, are both infections.
Mhm.
And then immunology, we're going to talk about in a minute under contact dermatitis. We're going to talk about those in
Okay.
a minute, okay?
Okay.
But you're on the reservation and you're totally there.
Okay.
Okay, the next
So,
one is trauma. So trauma has to deal with directly with burns. So open wounds, burns, compression wounds. So what would a compression wound be? There's a term that we talk about a lot in this section that deals with compression injuries.
oh, I don't remember. I know. I do remember about the healing by the secondary. What's the other word that I needed?
Hi.
Well, what? Hey, Hala, how are you?
Sorry I'm late. I just got home.
Oh, sorry, Addison. I thought you were Hala for there a second. I'm sorry.
Oh, you're good.
Sorry. So for you, Zakia. So
Yeah.
what I was talking about is like bed sores. Bed sores are all compression injuries.
Okay.
So
So
bed sores would
compression.
be compression. Yes.
Okay. Anything by like pressure on the
Yes.
skin can cause problem. Okay. Compression injury.
Compression injuries would be considered would be considered sorry, bed sores would be considered pressure wounds. Okay. Now let's talk about this one. So body states that cause decreased circulation. Can we name a couple of those?
Decrease circulation.
Yeah.
Like
So what are some conditions that decrease circulation in the body?
Diabetes?
Diabetes is definitely one of them. That is correct, Addison. Are there any other ones?
ischemia.
Smoking?
Smoking is one of them.
Mm,
Here's a really good one: congestive heart failure. Have we ever heard of that?
yeah, I think we she mentioned it in the cardiovascular one, congestive. Yeah, it has a definition though. Forgot it, but I heard definitely heard about that.
So let me go through these really quickly. So so body states that cause decreased circulation can either be local or systemic. So obesity, smoking, congestive heart failure, bedridden patients or those with limited mobility, PAD, DVT, etc. And then you guys talked about diabetes. Okay. So what I've done, ladies, is I've actually compressed and I've put body states that cause decreased circulation and body states that cause compromised immunity. Those two I've just put together because some of these are so closely related. They're so closely related. It's almost embarrassing not to talk about them together. So those two I talk about together. So decreased circulation and compromised immunity. So basically, you guys hit most of them. But cancer, AIDS, CKF type and type 1 and type 2 diabetes, and steroid meds all decrease immunity response. And we need to be really careful with those. Those will aggravate and cause um, immunity problems, or I mean, sorry, integumentary problems. Okay, we good? Let's move on. Let's move on. Let's move on. Let's move on.
So
Actually, let's do
so
one
you
thing.
said
Sorry, go ahead,
sorry.
Zakia.
So you said just like it's local and systemic. What's like what the ones that you said is mostly systemic. Which one that will be local?
Well, let's talk about some local ones. Okay.
So diabetes is systemic. Huh?
Yeah, let's keep going. So diabetes is systemic.
Uh huh.
So
Obesity is
diabetes is systemic. Can we think of any that would be local?
burn. burn would be local, but like
But
what
yeah,
you're
a burn
saying
would be
that.
local. A burn would absolutely be local and would definitely cause, and would definitely be an integumentary injury that would make you. Here's a question though, ladies. If you've been burned once, how well does your body respond to burns the next time?
Probably not as well because
Yeah,
the
so
skin is like, what's the word for it? When the cells and stuff don't work as good as they would have the first time.
they're already compromised.
Yeah.
They're already compromised at that point. Okay, so that's perfect. Okay, now let's talk really quickly about the skin. So who can tell me the 3 major layers of the skin? Little anatomy review, ladies.
Hello.
Yeah, you there?
Yes.
You guys there, ladies?
Okay.
So what are the 3 major layers of the
Okay.
skin?
Yeah.
Do you remember what they are?
What's that?
Okay, hold on. Let me take a step back. Okay, I think we're all driving and we're all a little. Everybody take 5 deep breaths. Everybody, ladies, Addison and Zakia, everyone take 5 deep breaths and not think about pathophysiology for a second. It's okay.
Okay.
I can do that.
That's 2. 3.
I already finished the 5.
4. Okay, the reason I took 5 deep breaths is this is getting crazy. Okay, we need to be calm if we're going to learn effectively and use our time the most effectively. So let's slow down for a second, take a step back, and make sure we can all hear each other, and that whatever we're doing safely. So if you're driving, please be cautious in the weather, and let's not die. And then if you just got done from work, take a deep breath and purge your mind of work stuff so that we can focus on this. Okay, is that fair? Is that a piece of good advice?
Mm-hmm.
Even I'm trying to do 3 different things right now with work, and I'm trying to send a bunch of emails out. Okay, so I had to stop. I stopped doing that right now because I realized how inappropriate it was, and I was not focusing on you guys as well as I should. Okay, let's get back into this. Okay, so we talked about the risk factors.
No.
Okay.
Mm-hmm.
So Zakia, you have something to add?
No, I didn't say anything. I just
Okay.
wanna like just cross through the Bangor Highway, so you
Okay.
might lose my voice for a second. But
That's okay.
yeah.
No, you're okay. I want you to
But
drive safely.
Mhm.
Yep, drive safely as opposed to crash your car. Okay, is that fair? Okay, so if we lose you right in the middle of your conversation because you're driving appropriately, that's what I'm telling you to do. Okay, here we go. So let me do this. So the risk factors for the integumentary system, okay, are skin pigmentation. Those with fair and light colored skin and colored hair are at higher risk of skin problems. Okay, ethnicity. Caucasians traditionally have the highest instance of skin problems. Okay, exposure to chemicals, radiation, and excessive sun are also put all people at higher risk for skin irritation and for skin problems. Trauma due to burns, due to open wounds, and due to compression injuries are all at higher risk for skin problems. Okay, and then we talked about compression wounds or injuries being a big one that we talk about in this section being pressure ulcers or bed sores. Okay, then pathogens put us also at risk. So biological, viral, fungal, and parasitic all put us at higher risk. Okay, now so body states causing decreased circulation is one, and body states causing compromised immunity is the other one. Okay, so under decreased circulation, we can have either local or systemic, and those would be situations like obesity, smoking, congestive heart failure, bedridden patients or those with limited mobility, PAD, DVT, etc. There are probably a few more, but those are the basic ones. Now, let me ask you ladies a question. Can someone tell me what PAD is?
PAD.
I think I know what it is, but I wanted to see if either one of you know it.
I don't know
I don't.
exactly, but
Okay.
Yeah.
You want to venture a guess, anybody?
I'm assuming like pulmonary, something like a clot.
Yeah. So pulmonary artery disease.
Okay, yeah.
Okay, I think so pulmonary artery disease, that's why I wanted to take a step back. And then DVT is deep vein thrombosis, okay?
Mm-hmm.
Okay, then body states causing compromised immunity are cancers, AIDS, and HIV. CKF. Does anybody know what CKF is? That was one that I couldn't figure out.
CKF?
Yeah, CKF. So Charlie Foxtrot, sorry, Charlie Kilo Foxtrot, or CKF. That was
don't
when I was having
remember.
a hard time with. I'll have to look that one up. I can't remember what that one is. And then type 1 and type 2 diabetes, and then steroid medications, because steroid medications just decrease the immunity, and they also decrease inflammation. They do both. Okay, are we cool? Are we all taking a deep breath, and now we're kind of all on the same page? We've all decompressed from work. We're all driving safe. Is that safe to ask that now? Because it was a little crazy there for about 5 minutes, and I was like, we're getting absolutely nothing done because we're all like got our brains in 3 different places. Was that pretty fair? I mean, was your brain still at work a minute ago?
Well, I go to work at 6:30 tonight.
Oh, okay. So you're thinking about going to work, and then Zakia's driving home, and then I'm like going to my advanced EMT class, and I got 3 other things going. So yeah, okay. So now that we've kind of crossed that bridge, and I've marked CKF, so to make sure to look that up, let's talk about the different layers of the skin and make sure we know what we're talking about. So in the skin, what is the very outer layer of the skin, or the ones closest to the sky and the sun? What's that layer called?
Dermis?
Okay, epidermis. That's the epidermis, or on top of the dermis. Okay,
Okay.
what's the next layer called? You just said it,
Dermis.
Zakia. That's the dermal layer, and then what's the one below that one called?
Subdural.
Subdural. It's either subdural, hepodural. They say hepidural in our notes, or it's subcutaneous. Those are the 3 that you can say that last one 3 different ways. Okay. Now I think it's important to remind ourselves what's in each of those layers. So in the subdural or the subcutaneous layer, what's in the subcutaneous layer, the very bottom layer? Why is that layer important? You guys can go ahead and look at your notes. It actually shows some of the structures. I think if you see the structures, it might help you a little bit. So go ahead and look at your notes real quick and just get familiar with the structure again. So in the subcutaneous layer, that's where all of our subcutaneous fat is. That's where our fats in the skin are. That's also where the major blood vessels, the veins and nerves, run through there. The veins, arteries, and nerves run through our subcutaneous layer, and they send offshoot capillaries up into the dermal and epidermal layer in order to feed those higher levels. But those aren't major; they're just offshoot branches. The major blood vessels are down in the subcutaneous layer. Okay, so moving up to the dermal layer. So in the dermal layer, that's where all of our sebaceous and merocrine glands are all. That's where those glands originate. They originate in the dermal layer, as well as the hair follicles, and then those move up to the epidermal layer and shoot out, and then perform their functions in the epidural layer up at the top. The ducts lead out, if that makes sense, but they actually originate in the dermal layer. Okay, then. And that may not be entirely true. It looks like the sebaceous gland originates in the hypodermal or the subcutaneous layer. But just overall, as you move up, you start to get structures moving up. Okay, and then in your epidermal layer, that's where your keratinized skin is at. That's where our water and protective skin layers are at. That's traditionally dead skin cells, the ones that have shed their nucleus, and they act as more of a protective function. They keep us from getting hurt. Okay, we good? Are we all on the same team now?
Yeah.
Okay, so the next part that we didn't spend any time yesterday talking about was risks for fungal, risks for bacterial, and risks for bites and infestations. So let's really quickly go over these. So Addison, are you on page 1 of the notes?
Yes.
I know that Zakia is driving, so I'm not going to ask her to read anything, but will you go ahead and just read out the paragraph for risk for fungal infections?
Yeah, so risks for fungal infections, debilitating disease,
Yep.
poor nutrition, poor hygiene or poor hygiene care of patients by care providers, tropical climates, contact with infection source, pools, footwear, excessive sweating, moist clothing, diapers, and incontinence underwear.
Okay. So what are the major things there for fungal infection?
Basically, hot.
Yeah, so basically those guys there, they basically have just the basic risk factors for cellulitis and dermatitis. That's really what they're saying. Okay, so fungal infections have a high component for hygiene. They have a high component on our part as caregivers. If we keep the hygiene up, these folks probably won't get fungal infections. Okay, the other part, what was the other part in there that they talked about near the end? There is a huge water component to this.
Yeah.
If their skin is wet, they are going to develop a moist fungal infection. Okay. Now let's look at bacterial and see if we can identify some differences. And I'll read this one. Risk for bacterial conditions, page 1160, 1156 and 1157. Staphylococcus and Streptococcus bacteria, most common bacterial cause. Compromised immune system, HIV, radiation, and/or chemotherapy, open wounds, poor sterile techniques by medical staff, being in a hospital, exposure to MRSA, and multiple other drug-resistant organisms are still a major problem. Examples are impetigo, superficial skin infection, and cellulitis, deep skin infection. So what is the major differences between bacterial and fungal? So I'm just adding a note here that fungal is hygiene and water-based, and bacterial is immunocompromised. That is the major difference between the two. That bacterial has an immunocompromised component to it, where I didn't hear any of that up in the fungal. It didn't say, "Oh, this person's got, their HIV." It was like, "Hey, this person's got like sweaty, nasty feet. They never change their socks. They're going to get fungal infections." Hey, the person with bacterial infections could have great hygiene, and because they got HIV and they're getting chemo and stuff, that staph and strep they just get out of control and they invade. So let me ask this question, ladies. If bacterial infections are Staphylococcus and Streptococcus bacteria mostly, how do we treat those?
Antibacterial?
Yep. Antibiotics, correct? That's how we treat those. How do we treat fungal infections?
Same. Antifungal?
We give them antifungals, but let me ask you a question. If you give somebody, now this is a question that's a little bit more treatment based. If someone has a nasty raging case of athlete's foot and you give them a topical antifungal like like Desenex or something, and you put their feet right back into a pair of sweaty, nasty, wet shoes, how effective is your treatment going to be?
Oh, so we have combined antifungal and hygienic.
Yeah, so we're going to actually clean their feet. We're going to completely dry their feet, and then we're going to apply a topical antifungal cream, and we're going to keep their feet dry and exposed to the open air. We're going to let air move around those feet to kind of air those out, get those dried off, get all that fungal off, and then we're going to let that topical ointment treat that fungal infection and bring it under control. Where bacterial, there's none of that. I mean, yeah, you're going to want to keep them clean, but if you give them antibiotics and they're in a fairly safe environment, they're going to probably be okay and they're going to respond well, and it's going to kill the staph and the staph, and it's going to solve their problems.
Okay.
Okay, does that make sense? Okay, let's talk about, so Addison, will you read bites and infestations?
Yeah. Living in overcrowded conditions, unsanitary conditions, areas of standing water where insects breed. It says, note, West Nile virus, which is spread by infected mosquitoes, is a particular problem in Utah and can lead to encephalitis.
Yep.
Encephalitis with permanent neurologic / physical disabilities.
So let's ask ourselves a question. Between insect bites and the other two, fungal and bacterial, which one does insect bites and infestation sound the most like between the other two?
Bacterial.
Well, let's ask this question. So which of the other two components had a large water piece to it?
Oh, fungal.
Fungal, right? So again, when you hear, and this is another good example of my military experience, when you hear about trench foot, which is a water-based foot condition of immersed foot, we almost always get malaria and other insect-borne illnesses with them. We don't hear as much about bacterial infections. They're still going to have an opportunity to get those, but they're going to usually have fungal infections with insect bites, introducing other stuff to them. Okay, does that make sense? So for insect bites, we just know that with insect bites, it's most closely related to fungal first. And then, yeah, obviously you could
With the
get,
insect bite?
yeah,
Mm.
because look, at insect bites has unsanitary conditions and fungal has poor hygiene. And then insect bites also has standing water, and fungal also has showers, pools of infected water, footwear that sweat, excessive sweating, moist clothing, and diapers and incontinence underwear. Well, again, most people who get foot problems, it's because they're around bodies of water. They're hiking out in the mountains with bodies of water and their feet get wet. Okay, well, if they're hiking around bodies of water, then there's clearly an opportunity for those insects to be present as well.
Okay.
Does
Sounds
that
good.
make sense? So the way to remember, I think, these ones is to just say, listen, so bacterial has that immunocompromised component. It's immunology based. Fungal is hygiene and water based, and then insect bites and infestation are based on standing water and the introduction of those vectors, those insects into an area. So again, let me ask you a question, ladies. Right now outside in Utah, how likely are you to get stung by a mosquito out here and get West Nile virus on a day like today?
Oh, very low.
Yeah, why?
Because it's wet. It's not summer now, right?
Yeah, the weather is so cold that insects like mosquitoes hibernate. They don't survive in cold weather. So if we're working at the hospital, are we expecting to see very many insect bite / West Nile virus cases between November and probably the 2nd of February?
Oh, so we usually will see more fungal problems since
Yeah,
people
we're gonna see a lot more fungal right now. Why?
because they are in boots and with their boots like more than 10 hours a day, and I don't know. That's what
Well,
I
look
think.
outside right now. It's raining right now, right? How many of you guys have been outside at all today?
I just came from outside.
Are your feet currently wet?
No,
Okay, well then
but
you're lucky. My feet were
I think
my
I
feet were a
think a
little
little
wet
bit
coming
from
in.
my toes.
Okay, my feet were a little bit wet when I came in from helping Amy Elizabeth and Harmony study for their exam. I came from the school, and by the time I went to my car at school, got in, and then got in my house, my feet were a little bit dry. I mean, a little bit moist because I'd been walking through the grass and I'd been out a little bit right in that rain, that heavier rain that we had earlier today. Okay, so I'm a little bit more apt to have fungal infections. So tonight at work, I'm actually going to take an extra pair of socks with me to work and an extra pair of shoes just in case my feet get wet. I'll be able to change them out and not have my feet immersed in nasty wet shoes all night.
Mm-hmm.
And
Okay.
that'll help to reduce any fungal infections because I already have a predisposition to some foot fungal, like, to athlete's foot anyway. Just because my feet, I've spent a lot of years in boots with them wet, and so now I'm a little bit more predisposed. I mean, I get athlete's foot at the drop of a hat. Okay, so if we beat that to death,
Yep,
so we
we
added
did.
so we added some stuff from yesterday, correct?
Yep.
Got a little bit more detailed. Let's go through the rest of these as quickly as we can because we only have about 15, 20 more minutes to get through these. So let's hit cellulitis really quick. So what was the one-liner for cellulitis that we talked about yesterday? Does anybody remember?
Bacterial infection.
So yep, those are bacterial infection, and so those are strep and staph related. Okay, let's
Strap
move
and
on. What was that?
strap and what?
Strap, staph infection, staphylococcus and staphylococcus.
Oh,
So
okay. So the two. Uh-huh.
staph and strep.
Okay, good.
Okay, what about contact dermatitis? What was that one's really weird thing?
I don't remember that one.
Remember,
Oh,
it
it's
was
like
go
type
type 4 what?
hypersensitivity.
Type 4 what?
Hypersensitivity
Okay, so what is type 4 hypersensitivity, Addison?
delayed.
It's delayed onset, right? And remember the other key thing
Mm-hmm.
about this one was that if we have type 4 delayed, what does this want to develop into?
I mean, let's see, immune complex, you mean? Like, or what they
Yeah,
would
yeah,
develop?
no, it'll go from type 4 to type 1. Type
Oh,
4 will develop
anaphylaxis.
into it'll develop into type 1 anaphylaxis.
Okay.
Okay? So that's
Okay.
contact dermatitis in a nutshell. Okay? Let's move on. Okay?
Okay.
So pressure ulcers. So let's just really quickly hit pressure ulcers. And there's two things that I want to definitely hit. I want to talk about the two things that cause it. I want to talk about the risk factors, and I want to talk about the stages. Can we do that in less than 5 minutes?
Yeah.
Okay, so what are the two things that directly cause pressure ulcers?
Shearing is what I remember
Shearing
from.
is the one that I was hoping you'd get. So yeah, that one. And the other one is in the name of it. Well, the other one's in the name. Unrelieved pressure. So unrelieved pressure and shearing forces cause pressure ulcers. Now let's get into the risk factors. And Addison just gave one. Limited mobility is definitely one of those risk factors. Are there any other ones? Do older or younger people get bed sores easier?
Older.
So older age. Okay, what about moisture? We call that incontinence pads.
The maceration.
Okay, maceration, yes. And then Addison already got mobility, limited mobility. What are some other ones that are a little bit less common or we don't think of as easy?
Less common on the one on back in your head.
That's a point where it can happen. I'm talking about smoking.
Oh.
Smoking is a risk factor. Why?
Because it affects the skin directly, I guess.
It affects vasoconstriction. It vasoconstricts those blood vessels leading into the skin and causes them to be more susceptible. Okay. What about nutritional status?
Yeah, but will be the least less like risk factor, I guess, right?
We just know that someone who's not getting the nutrition that they need isn't going to have the proteins and the energy, the building blocks to be able to rebuild skin if it gets damaged. They're going to have an impaired skin response, and they're not going to repair damage as well if they get damage to it.
Okay.
Okay, we good?
Yeah.
Okay, what about diabetes? What's going on with diabetes?
Because they don't have a sufficient circulation.
Yep, that's also vascular based, correct?
Mm-hmm.
Okay.
And the last one is steroids. They're using steroids, specifically prednisone, and that causes an anti-inflammatory response, and it also suppresses the immune system. And we said that immunosuppression also causes us to be more susceptible. So there are actually 7 of those risk factors. Let's go through them one more time really, really quickly and hit them all. And then we'll move on to the stages, and then we'll move forward into cancers and burns, okay? So let's do it together. Number 1 is age. So say age.
Age.
Okay.
Age.
Number 2 is incontinence or maceration. So say incontinence or maceration.
Okay.
Incontinence
or maceration.
Okay. Number 3 is mobility limitations.
Mobility limitation.
Okay. Smoking.
Smoking.
Nutritional status.
Nutritional status.
Diabetes.
Diabetes.
And steroid use.
Steroid use.
And then what was the specific steroid that we talked about in this? It starts with the PR.
Prednisone.
Prednisone. That is correct. Okay.
Prednisone.
So what's the question?
Yeah.
There's a question.
Yeah. Why the steroid will cause that?
Because it's suppressing the immune system.
Okay. Got it.
And that's why it's having that. Okay. Who can give me the 5 major stages with suspected deep tissue injury in the front and unstageable at the very end? Who can do them all?
Let's see. Is that the ABCDs?
No, this isn't the ABCDs. This is, hey, I've got stage 1 pressure ulcer. What is a stage 1 pressure ulcer?
That's when you yeah.
Yeah, give me the one-liner. So how would you describe me in 1 or 2 words a stage 1 pressure ulcer?
Sharp.
So sharp, intact skin. The skin is intact, and it has redness that is not relieved when it's touched.
Okay.
Okay. And we call that blanching test. When we blanch it, we push on it, it stays red, even if we push on it. That's stage 1. Stage 2, what's going on in stage 2?
Blister.
It's like a blister.
It's like a blister, right? So now we've invaded into the lower level of the dermis. It's moved from the subderm. It's moved from the epidermal layer. Now it's starting to move down into the dermal layer through the epidermal. Okay. Mm-hmm. Is the skin still intact in that one?
No.
No.
Yep. Shallow opening. There's a shallow opening with that blister, and there's a pink wound present, okay? What about stage 3?
Yeah, that's a hard one. I think what I remember, they need to like, you need to kind of measure how deep is it.
And there's a name for how we do that. How do we measure it? It's called undermining.
Undermining. Okay.
And that's where we use a cotton swab and we put it up underneath that layer of skin around the outside of it. We start to push in there. We're looking for how deep it is, how penetrating it is, and we're looking for tunneling to see if that's starting to move.
Okay.
Okay. And then that one stays above the subcutaneous layer. So now we've invaded the dermal layer, the epidermal layer, and now we're getting into the subcutaneous layer, into those fats. Okay. What was that?
What they call it again?
And undermining.
Undermining.
Undermining. Okay. What's stage 4?
When you can. Wait, how many stages is there? 5?
There are four
Four.
stages. I'm sorry, 4 stages, and then there's the unstageable, and there's what I like to call pre-stage 1 with suspected deep tissue injury. Okay, let's not worry about those right now. Let's just hit stage 4. What's stage 4? It's the craziest, nastiest one.
Where you can see the bone.
Yeah, it started to invade down past the subcutaneous layer. We're going to have deeper tunneling. We're going to have deeper undermining, and it's invaded into the muscle, bone, joint capsule, and tendons. It's invaded down past the subcutaneous layer into those tissues. Okay. What's unstageable? What's the key word for unstageable? There's a really weird medical term we use for that, for unstageable.
It's called, but when the skin is like turned black.
Yep, and there's a name for it. It's got a really funny French name for it.
Yeah, it has a name.
Eschar.
Eschar?
Eschar is the term for that black, leathery, nasty, dead cells, right? You can also call it necrotic tissue.
Yeah, that's what I was thinking. It's like necrosis. That's from necrosis tissues. I was like,
the only reason that I'm pushing Eschar is because Tana pushed it. She said it multiple times yesterday. So clearly we're going to see that on an exam, right? They may say necrotic tissue, but they may say Eschar, and we need to know that Eschar is that black, dead tissue. Okay, so now listen, ladies, there's one more category here, and it's called suspected deep tissue injury. And this is what I like to call pre-stage 1. This is going to be things that we're looking for to try to detect before they even have stage 1 pressure sores, right? And I'm just going to read this one out because it gives some very, very distinct color that's not in the other ones. So purple or maroon localized area of discolored intact skin or blood-filled blisters due to damage of underlying soft tissue from pressure and or shear. This area may be preceded tissue that is painful, firm, gushy, boogie, or boggy, warmer or cooler as compared to the adjacent tissue. And they call that pre-deep tissue injury. So it's basically before stage 1. So if we could detect that stuff before and deal with it, then we don't even have to deal with pressure ulcers. So let's do that, okay? Well, we're all nurses. Let's just detect this stuff early and deal with it and not have pressure ulcers, okay?
So pre-stage, that's as like that, the video that we watched. So it will be red. It's kind of tender to touch, right?
Yep, it's going to be it's going to be tender to touch. It's going to be warmer or cooler than the skin around it, and it's going to start losing its color, and it's going to start moving a purple or maroon color before it goes into that stage 1.
Okay. I thought that's the stage 1.
No, there's one called pre-deep tissue injury or syndrome, and that's prior to stage 1. If we can detect that and relieve it and deal with it, we won't even get to stage 1, which is awesome.
Okay, so what's the difference between this one and the stage 1? Like
the color. Okay, the color of the stage 1 is intact skin with unblanchable redness. Okay, unblanchable redness is stage 1, where suspected deep tissue injury is purple or maroon, and you're going to get blanching with this one. When you push on deep tissue injury, that purple and maroon color is going to disappear. When you remove your finger, there's going to be a white spot there, and then it's going to slowly, gradually return. Okay. It's going to be blanchable. Okay, did we beat that to death? Let's hit these cancers. Let's hit these cancers really quick. So who can tell me the 2 types of benign cancer that we'd learned about?
Give us 10 seconds.
These ones both start with A. They both have an A as the start of their names.
Is that mast cell cancer?
So
No.
angiomas is the first one.
Is it
And
melanoma?
actinic keratosis is the second one. These 2 are both benign, not malignant. They're benign. They're not going to spread, and they're something that we can deal with. In fact, we don't even have to treat these. We can just leave them if we need to. Okay, because they're not going to get worse, and they're not going to be malignant. Okay, so angiomas are not malignant. They're not cancerous, and actinic keratosis has a second name to it. It's called solar keratosis. Okay.
Oh
And
my gosh.
it's these small lesions. They're small lesions that form due to sun exposure. And then if they're left untreated long enough and we don't help this person get out of the sun, those can develop into a certain kind of cancer later.
Okay.
Okay, let's get into the malignant cancers. There's 3 of them. Does anybody know any of them?
Is
The
one of
one-
them melanoma?
So what was that?
I said, is one of them melanoma?
One of them is definitely, say let's use the correct full term for these, melanoma carcinoma. That tells us it's malignant.
Okay.
It's the carcinoma that tells us it's malignant. So yes, Addison, melanoma carcinoma is very, 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 very bad. Okay. Do you know any other ones, Zakia?
It's the name of a cell. It's either like mast cell or like it starts with the B, and I don't remember it.
You are on the reservation. The next 2 have the name of layers of the skin. One is called basal cell carcinoma, and one is called squamous cell carcinoma. Now, ladies, let's put these in order of most malignant to least malignant or least dangerous. So which one is the most malignant or the most dangerous? If you get it, it can be the most dangerous.
Melanoma.
Melanoma is definitely the most dangerous, and it is the least common.
Least common.
It is the least common, but it is the most dangerous. If we get melanomas, those are going to be the ones that we really want to treat aggressively because they're going to metastasize and move the quickest because they've invaded deepest into the tissue layer. So they've invaded past the epidermal, the dermal, and the subdermal or subcutaneous layer, and now they're getting down into the muscle, the joints, and they have access to the blood and the lymphatic tissue. And that's why they're most dangerous because those skin cells can break off in those highways or pathways, and they can go lodge somewhere else and cause a lot more problems.
Okay.
Okay, what's the next most dangerous one? Squamous or basal cell?
I think basal.
So squamous cell is the second most common and the second most lethal. So melanoma is the most common, it's the most lethal, least common. Then it's squamous cell carcinoma is the second most common.
And
the second most common, and then second most lethal.
Second most lethal, okay.
And then basal cell carcinoma is the least lethal, but the most common.
Okay.
Least lethal, most common.
Most common. Okay.
Yes, least lethal and most common.
Nice.
Okay, that's the cancers. Let's hit burns really quickly. So there are 3 kinds of burns. Can you remember what those are about?
There's 3 stages or 3?
There's 3 kinds. They're not stages. There's 3 kinds. What's the first kind called? And it's also the least. It's the one it's not the worst. This is the one that's the like we can get this and not be in trouble. What's that one called?
Sunburns.
Yeah, sunburns, right? That's first degree or sunburns. Okay, what would characterize a second degree burn?
Blister.
Say again, Addison.
Blisters.
So yeah, blisters is going to be second degree burn. Okay, excellent, good. Second degree burns are going to be blistered. Okay, what about third degree burns?
They will be healed by the second. That type of second wound healing.
So yeah, second degree burns are going to have invaded down further down. Have going to invaded down further down.
Uh-huh.
And they're going to So second-degree burns, or excuse me, third-degrey burns have invaded down past the subcutaneous layer, and it's invaded down into further layers of fat. They're down to the muscle and the bone layer of that organ or that part of the body. That's third
Okay.
degree.
Okay.
Okay.
So they would be
So
closer to the circulation.
yeah.
Okay.
Yep. They're going to be in the circulation. They're going to be down in the bone and the tendon and the joints and stuff. That's where they're going to hit the bone basically.
Okay.
Okay, really quickly, what are the worst kinds of burns that require an immediate medical emergency on our part that we should be most concerned about?
I think the burns in closed areas.
Okay, so there's an overriding term for all those kinds of burns, and they're called inhalation injury. They're called inhalation burns.
Okay.
Anything dealing with burning of the face or hot air around the body at the time of the burn that can be inhaled, that's why we call them inhalation,
So in the
they are
face,
absolute.
where?
They're called inhalation, to breathe in, to inhalate, right?
Uh-huh.
Anything dealing with hot air around the face or burns around the face and neck is going to be a medical emergency immediately.
Okay.
Okay. That is clear as mud?
Mm-hmm. Yep.
Okay, clear as mud. Good.
Clear as
Okay,
mud.
clear as mud. Okay, guess what? We're done.
Oh my gosh. Okay, now is our part to go over it and see how we can
Yes.
connect all this information in.
Keep practicing. Keep practicing. Keep practicing.
Yeah. Okay, sounds great. Thank you,
Okay.
Chris, for your time.
Have a good
Thank
night.
you.
Have a good night, ladies. Okay, see you tomorrow.
Uh-huh.
See ya.
Okay, bye.
Bye.